Hi class, this video is going to talk to you a little bit about soft tissue mobilization in mechanical energy. My quote of the day for today is, as we grow as unique persons, we learn to respect the uniqueness of others. I really appreciated and learned a lot about you guys in your discussion posts this week, so thank you for putting your thoughts into that and sharing a little bit about yourselves and some of your study strategies as well. I'm going to be looking forward to our guest speaker next week, Anthony Ling, as he talks to us and shows us different techniques on soft tissue mobilization. Dr. Smith will have the handouts for you and they'll give them to you tomorrow or Monday. Okay? So here we go. Mechanical energy. So with soft tissue mobilization, we know that we're creating energy through the use of our hands into the soft tissue. Here's our definition: is the energy possessed by an object due to its motion or position. So we know with kinetic energy, that's that energy of motion. And then the potential energy is that energy that is stored. So in all instances in which work is done, there's an object that supplies the force to the work. When work is done on the object, that object gains energy. The energy acquired by the objects upon which work is done is known as mechanical energy. So as you can see, our hands are doing some work on the soft tissue of this patient, and this patient is then gaining some energy, which we hope is going to help facilitate some healing for them. So the foundation, the interaction of human touch, some of the things that theoretically we believe human touch creates. It eases anxiety, fosters some confidence, it promotes compliance, gives a positive outlook, and it promotes recovery and a favorable outcome. So by us taking that time to actually validate where the patient is complaining of pain, evaluating it with our touch, really gives your patient confidence that you know what you're doing, you care about them, you're empathetic, and it really does impact their outcome. So we talked about soft tissue mobilization versus massage, and these are just the definitions. Soft tissue mobilization is that manual manipulation of the soft tissues administered for the purpose of producing effects on the nervous, muscular, fascial, lymphatic, and circulatory systems. Thus, helps us with our billing to know that it's a therapeutic adjunct intervention for our patients, whereas if we put massage, the definition is the rubbing or kneading of a part of the body, even though we know, like, a massage therapist has hours and hours to become a certified massage therapist. When we are charting in a documentation, we will not get reimbursed for massage. So we utilize the terminology soft tissue mobilization, and that definition is probably important for you to know. So here you can see her doing a little bit of deep pressure in there, trying to assess the tissues and feel what's going on. You can see her body mechanics, the use of how she's using her legs. She's over the serum, she's kind of protecting her hands as well, and she's keeping contact on the patient, and the patient's in a relaxed position. The physiological effects of decreasing pain, muscle spasm, increased blood flow. It's not a lot of impact on deeper tissues, maybe a secondary effect due to the enhancing of the lymphatic drainage system. It stretches that connective tissue, we talked about that, versus it does this through that tissue extensibility, through that mechanical energy. And it also stimulates the sensory receptors of the skin and the superficial fascia. Okay. So here we go. Here's our gate theory again, when we talked about. You guys did a nice job of this on your exam. I appreciate I definitely, when I look at the point values on those exams, as far as how detailed you need to get, if you're not sure, you can always come up and ask me, but I was looking for you to be very specific on the types of nociceptive and non-nociceptive fibers, and which ones are myelinated or unmyelinated, and faster or slower, and how that affects that gate theory. So we remember that the A delta are the myelinated ones, and they are faster than those unmyelinated C fibers, and they're over here. And then we have the even larger myelinated A beta fibers that actually go even faster. You have the inhibitory chemical stimulants that are released, and then you get the sensation up to the brain of either pain or no pain. And so depending on the modality we're using this to which area it goes to. And so here's just kind of giving you, reminding you of that. When you touch the skin, and it stimulates those nociceptors. So our indications are for pain reduction, relieving muscle hypertonicity, reducing muscle spasm and trigger points, increasing our range of motion or tissue extensibility, increasing venous and lymphatic flow, promoting healthy scar tissue, reduction of edema, including lymphedema. It's just a very specific type of mobilization that we do for that. And respiratory conditions involving mucus, and so that's what we call postural drainage. You probably went over that in your acute or your neuro class. So trigger points are those hypersensitive fibrous bands of tissue. The focus of the hyperirritability in tissue that when compressed is locally tender and is sufficiently hypersensitive gives rise to referred pain and tenderness. So a lot of times, like in our upper trap or our levator or scapula, you can find a trigger point, and then it's really, really, really hyperirritable. It will refer down into either your shoulder, or it might refer up into your neck or down into your scapular blade. Myofascial trigger points are hyperirritable spot in the skeletal muscles associated with a hypersensitive palpable nodule in a tight band. It's painful, and compression can give rise to characteristic referred pain, motor dysfunction, autonomic phenomena. You have a Terrell book in the lab that has the different trigger points that you can follow. The fluoromethane vapor coolant spray that we had in lab this week often works on those trigger points. Also, when we get into the ultrasound and E-stim combo, you'll find that that's very effective on trigger points. And then there's certain soft tissue mobilization techniques that are really effective with trigger points. Areas that we want to avoid with our techniques of soft tissue mobilization would be the anterior neck, and this is because we have the carotid arteries and other vulnerable areas in there. Axillary region, again, because you have the brachial plexus in that area and your lymph nodes. Anterior posterior elbow region, again, superficial nerves in that area, the umbilicus, kidney region, inguinal region, excuse me, and the popliteal fossa region, which also in that back area you have a lot of nerves that kind of go through that area, and you can really irritate it. So it doesn't mean you can't massage back there, but you just don't want to massage deep in that area. Our contraindications is that the patient is ill or nauseated, they have severe pain, they have a fever, a recent serious injury, they're contagious or have infections, they have cancer that's spread in the lymph or the circulation, an area of bleeding or ecchymosis, acute inflammation or pitting edema, and a deep vein thrombosis or DVT. Other ones we have are severe atherosclerosis, varicose veins, decreased sensation, I would say, along with that decreased mentation, hyperesthesia, severe rheumatoid arthritis, and cellulitis are all contraindications. Precautions that we have, let's see right there, massage guidelines, considerations, and so up here we really should be saying soft tissue mobilization. Need to change this slide. You want to know the knowledge of the anatomy, physiology, and pathology. This is where your palpation skills will come in handy. So if you have time prior to the lab on Tuesday or Thursday, that you look over in your packet. There's some anatomical palpation points in there, and it would be nice for you to practice that so you'll be a little bit more prepared if you haven't done that yet. You need to want to have professional behavior. We're going to talk about proper draping, keeping modesty, and exposing the area that you need to treat. Clean, warm, dry, soft hands, and they should be short, manicured nails, and trying to avoid nail polish if possible. You definitely want to have good body mechanics. You really want your body to be emitting that energy so that you don't hurt yourself. The pressure, you always want to assess with the patient, how's that feeling, and you always want to start light and kind of assess it. the tissue so you don't miss anything, and then you can slowly go layer to layer once you eliminate all those barriers in between. Your rhythm, slow, generally speaking, relaxes the patient, allows you to pick up on things, how long you do it for, the directions that you do it. And we know with cross friction that you're doing it against the tendon, but a lot of them you're going with it, so it just depends on what your purpose is. You want to have some lubricant. I tend to not use a whole lot of lubricant in certain areas, especially when I want to get a real specific spot, but you do want some just to avoid that friction. You want to make sure you warmed your hands if possible. I have very cold hands, that warm heart kind of thing, so sometimes I even put my hands under warm water to begin with, so I'm not shocking the patient. You always want to start and end with that superficial effleurage that we talk about, and that's smooth transitions between your techniques and to keep skin contact. And I think that's about it. So here's your effleurage. You can see they're going and they're feeling, they're just assessing the tissue. They're distributing the lubricant that they're using, so it's there all over the area that they're assessing. The patient gets used to your touch. You can palpate for those trigger points and muscle spasms so that you can then use your Petrissage, which will be the next technique we talk to go a little deeper and try and clear that spot. I think that's good. Petrissage, so here we're getting those trigger points. So we're doing some kneading here, the directions toward the heart, greater mechanical effect. So you want to avoid pinching the tissues. That wouldn't feel too good. Yeah, I think that's it. And with this, you're actually not using the gate control theory. You're going to use what we call the descending pathways, and we'll talk about that a little bit to see how that decreases your pain, but in a different way. Now, these are just different techniques. One is called picking up. Here's one called ringing, and then there's also skin rolling to help assess where there might be areas of limitation that we can practice in lab. So this first top one is what we call a J stroke, and they found a trigger point, and so they're kind of gathering that tissue up, and they're going to try and release that. Here's friction massage. It looks like it's a lateral epicondylitis, and they're working on that extensor carpi radialis longus or brevis there in the cross-friction way to try and bake up the scar tissue that wants to line that's causing the pain. Here's somebody using a Graston tool. Oh, sorry about that. And then here's another cross-friction supporting one finger with the other finger on there. Okay. So here's that descending analgesic pathway that I was talking about. And so what happens is you have that alpha motor neuron to the muscle fibers. You have a muscle spindle, and the release of those afferents from the muscle spindle and the Golgi tendon organ that go into that brain that we were talking about. So good to know that that helps with how that relieves pain, even though it seems like it's painful at first when you're doing a deep tissue massage on people. There's other techniques that you hopefully will get to learn in myofascial release, the direct and indirect technique. There's a cross hands technique. There's that J stroke I was talking about, and strain counter strain. There's active release. There's a million different ones out there. So we'll try and do what we can do with the time that you have before you start clinics. And there they're just talking about the release of the opiates, and those will make you feel better. All right, that's it. Thanks.